meeting with smaller number of members and then grown over the last 15 years. In fact, we can trace its beginnings back to the 1990s. So it's a great work group. We are so pleased that people have joined. If this is your first time and you would like to be a member of the work group, please contact Samantha, and her email is on the website, and she'll make sure that you get notices in the future. It's also my privilege today to introduce Paul Estabrooks. And Paul has just moved. Many people may know him from the coast, most recently from Virginia, but right now he is at the University of Nebraska Medical School. He is very distinguished. He has a distinguished chair, the Harold M. Maurer Distinguished Chair, but he's also distinguished among reanimators. He's been here from the very beginning, and what I would say about Paul is he really walks the talk, and that is he's studying implementation research, but I think he's also been an instrumental person in helping us both disseminate and sustain implementation research, particularly around REAIM. But REAIM hasn't stayed the same. It's changed over time. So the topic of today's application of the REAIM framework and looking at effectiveness implementation with hybrid trials. So with that, I would be very pleased to introduce you, Paul, and just have you take it.
Okay, thank you, Marcia. And let me say, it's really exciting that I am hearing a lot of clicks joining the meeting. One thing that I am also noticing, though, is that if your phone isn't on mute, it's connecting and giving feedback. So if you wouldn't mind putting yourself on mute until we get to the questions part at the end, that would be really great. And I think that it's already cleared up pretty well. All right, well, thank you, Marcia, and thanks everybody for coming out to see this presentation today. It really is more of a discussion starter than what I would consider a formal presentation. So please feel free to go ahead and ask questions and type those in there, and Samantha will be gathering those for us to ask at the end. Thank you for coming. So one of the things that we've been struggling with over, oh gosh, I guess it's probably since Curran wrote his paper on hybrid effectiveness implementation designs, on how that relates to REAIM and how we might apply REAIM across these different types of trials. And so I'm going to start out with, there we go, I can get it. So I'm not going to give a whole bunch of background today on REAIM. I'm going to assume that most folks on here have a good sense of what the REAIM framework is. You can see each of the dimensions up there on the snappy logo that we created a few years ago. And what I wanted to really kind of focus on was this idea of the effectiveness implementation hybrid designs. And you can see on the screen there, this is the paper from, actually there was, I thought, was there an earlier one? Maybe, I think this is the paper that Jeff Curran came out and his colleagues, and they put really nice definitions to what these types of hybrid designs are. And there's 3 of them. And, you know, one of the things that is interesting here is that he cites, or they cite, Russ and others, that it talked about kind of blending together efficacy and effectiveness trials with the idea that that would help people to get evidence-based research into practice in a quicker way. And one of the things that they highlight here is that with these hybrid designs, what they're trying to do is blend components of what we would consider clinical effectiveness trials with implementation trials. And the idea here is very similar to what we talk about with REAIM. The idea is that by understanding the degree to which a clinical intervention is effective, while also assessing implementation barriers, facilitators, or even interventions, gives us better information on both the internal validity of that clinical intervention, but also the external validity related to how this would actually be delivered in a typical setting. And most of the work in this area has focused on healthcare settings, but of course, you know, a lot of the folks that are on this call today do work that is not strictly within the clinic, but is with community organizations, and we would think of that blending as well, and this being very applicable to community trials that are, or community interventions that are trying to improve health. So there's 3 types of hybrid designs, and so I'm going to go over this fairly quickly and give you some high-level descriptions of each one, but I would encourage everyone to pull out the Curran et al. Paper from 2012, and we'll be posting this webinar and these slides on the REAIM website, which is www.reaim.org with the hyphen in that, REAIM. So if you need the references and that kind of stuff, you'll be able to get there. But a type 1 hybrid design really focuses on effectiveness. And it's similar to what we might consider an effectiveness trial, with the exception that there's a lot more attention paid to the implementation of that clinical intervention. So if you look through the bullets here, it focuses on effectiveness. It tests a clinical or a community intervention that is intended to improve patient health. You can see the patient or the participant who is intended to have the health benefit is the unit of analysis, and the primary outcome is typically change in patient health. And so if we want an example of this, this one, and I apologize for, I'm sure, ruining the pronunciation of the lead author on this paper, Baidas, gosh, I hope I said that okay, and colleagues, and this really comes from some of the work that Katie Schmidt has done in trying to develop strength training interventions to help after breast cancer. And so if you look through this, kind of the key parts of hybrid type 1, I'm hoping you guys can see my mouse on here. You can see it's to quantitatively assess whether an evidence-based exercise intervention for breast cancer survivors, strength after breast cancer, was safe and effective in a new setting, and here's what makes it the hybrid design, to qualitatively assess barriers to implementation. And so, you know, if they had stopped right at that and, it would be a typical effectiveness trial where we have good efficacy data. Now we're going to take this into a typical practice and test it out. When you look down and, oops, I didn't mean to do that. I'm sorry. How do I get myself back there? Boy, itchy trigger finger there. Apologies for that. When you look down at the results here, again, you can see kind of the key piece of a hybrid design where it talks about the effectiveness trial. It worked to improve lymphedema symptoms, muscular strength, and body image. Now, the effect for the effectiveness trial was a little bit lower than the effect that they found in the efficacy trial, which is not unusual, but it worked out pretty well from an effectiveness standpoint. And then when you look down here, the second part of the results talk about their qualitative implementation data and talks about the barriers around intervention characteristics, payment, eligibility criteria, referral process, the need for champions, and the need to adapt the intervention during implementation, all as issues that could arise when someone is trying to take this type of intervention into a typical clinical practice. So there's not a whole lot of difference from the type 1 from an effectiveness trial, with the exception and a whole lot of work in collecting qualitative, descriptive, and sometimes even quantitative information on the implementation. And so then we'll move on to the type 2 hybrid design. And this one is, I think, probably the trickiest of them. It's the one that focuses on both effectiveness and implementation. And so the idea here is that you have a clinical or community intervention that's intended to improve patient or participant health, but you also have an implementation strategy or an implementation intervention that's intended to improve implementation outcomes. So things like treatment fidelity, cost. In some of these studies, they use REACH as an indicator of adoption and implementation. So really, you have 2 different interventions, 2 different sets of outcomes, which gives you 2 different units of analysis. And so you can see at the bottom, your co-primary outcomes are related to implementation and the clinical outcomes. And so an example of this one here is by Cully and colleagues. And again, I'll just kind of walk you through it. And I know this is small for people that are looking on their screen, but I hope you can look at it and see it okay. But the idea here is that what they want to be able to look at is they say there's evidence-based psychotherapies for depression and anxiety, but they're underused in areas such as primary care. So they wanted to determine how well these types of evidence-based psychotherapies would compare to usual care when they're delivered in a typical primary care setting. So that's the effectiveness side of things. But then they're also interested, as you look down a little bit further, to examine the acceptability, feasibility, and preliminary outcomes of a focused implementation strategy on improving adoption and fidelity to the cognitive behavioral therapy at 2 primary care mental health integration clinics. So again, you see within this one, the distinction from the type 1 is that we still have a clinical intervention and we're still comparing it to something, but now we also have an implementation intervention that we were also comparing to something. So does this implementation strategy work better than, say, our usual announcements in our clinical meetings and those types of things? So kind of a standard care. So now, and yeah, I wanted to point out this. This is a really nice figure that that's in this Cully et al. Paper. And the thing that that kind of gripped me on it that I liked a lot is that it just gives a very simple, straightforward view of where these hybrid designs fit. And so if you look, you have efficacy research, effectiveness research, and it's probably for another talk to determine whether we need that clear distinction there. But in between that effectiveness research and implementation research, you have these different hybrid models that in each case you still have some level of focus on effectiveness and implementation, okay? So that's a nice figure for anybody who wants to do a talk on this sometime. And so then we get to the type 3 hybrid design. Can people still hear me? Yeah, I'm sorry, something just dropped here. Okay, so we get to this type 3 hybrid design. And the focus on this one is really to test an implementation strategy or an implementation intervention. And it also provides, on this case, it kind of flips it around where it's really descriptive information on the patient or participant outcomes. And so from this standpoint, you're really focusing on, number one, are we getting good implementation fidelity, or are we getting good costs of implementation? And then secondarily, by improving that implementation, do we actually see improvements in patient or participant outcomes? So for this type of design, the staff or the setting is the unit of analysis, and the primary outcome is typically adoption, implementation fidelity, and as I'll show you with this example, reach as an indicator of adoption. And so here's our type 3 example, and I apologize for the blurriness on this one. I tried it a couple of times to get it so it wasn't quite as blurry. But here they have a care management implementation strategy. So they have a new strategy for care management that's feasible to deploy in routine care, and hopefully by using that care management approach, they will get better implementation of depression-related evidence-based practices. And so if you look through here, this one, here's our method. The multi-site hybrid type 3 effectiveness implementation study employed a pre-post quasi-experimental design. The study was conducted in 22 veteran affairs, community outpatient clinics, and the evidence-based quality improvement strategy was used to facilitate and promote adoption. Right, so the outcome here is really the uptake of the evidence-based really was the uptake of the care management program, and then the outcomes that they used to try and determine if the folks in the clinical setting had actually, the delivery agents had picked that up, was that they looked at reach into the target population at implementation sites, so where you had that care management, and you can see that the odds ratios showed that once they got this care management intervention, that they began, the reach of the clinical intervention increased over time as the indicator that they were getting more implementation. So this one's a little bit less clear, and let me tell you, I had a hard time finding anybody that this was about the only example that I could find. So if anyone out there has examples of type 3 hybrid implementation effectiveness designs, please send that along, because we'd love to be able to review that. So now that I've gone through that, I wanted to kind of highlight what a REAIM research mission is. And, you know, we use this in our group as our research mission. I believe that this was something that Russ developed a long time ago. But the idea when we talk about REAIM, which has some really good connections with these hybrid types of designs, is that we want to develop and test health promotion, behavioral program, policy, and practice interventions that can be adopted across a variety of settings, have the ability for sustained and consistent implementation at a reasonable cost, reach lots of people, especially those who could benefit most or those who are experiencing health disparities, and produce a replicable and long-lasting health benefit. Okay, so that's our REAIM mission. So that kind of reminds everybody, when we're talking about REAIM, we're talking about organizational level factors like adoption, implementation, and organizational level maintenance, as well as individual level factors such as the reach into the target population and effectiveness as it relates to change in the primary outcome, quality of life, and maybe some potential negative impacts that could occur as well. And so when we're applying REAIM to hybrid designs, and we've done this in a couple of studies now, there's some questions that you can start with. And where we tend to start is what dimensions from REAIM are you intervening upon? And when you're doing a hybrid design, it's one of two or it's two of two dimensions, effectiveness or implementation. And then the next question that we ask is, what dimensions can we provide some descriptive information on so that folks can have the context within which we did our research? And then what dimensions are beyond the scope of your study? And I think, you know, for folks that have submitted grants or papers and use the REAIM framework, and if you say, that you're using REAIM, but then you don't have a measure of organizational maintenance, you get criticized for that, when in fact, there are some studies where things like organizational maintenance might be beyond the scope of your study. And so really trying to be clear on the front end on what are we intervening on, what are we going to provide descriptive information on, and what things are just beyond the scope of what we're doing, and providing some rationale for that. And so then, when we ask those questions and we do a type 1 design, here's what the REAIM outcomes would look like. So reach here is typically descriptive. You're usually talking about the number of people who participated, your sample size. If you're doing a good job on this, you're also providing a relevant denominator of the eligible target population that were exposed to recruitment. And then you provide the proportion of those folks that were exposed to recruitment that actually engaged in your intervention or your study. And then finally, you'd look at the degree to which those folks in your study look like the target population on key variables that are related to demographics and those sorts of things. Then you'd look at effectiveness as the primary outcome and the target of the intervention. So here's where, we've now identified what our target is for the intervention. I won't go into detail on how you would assess that, because I think folks understand that pretty clearly. Then from an adoption standpoint with type 1 designs, it's typically descriptive as well, and often includes quantitative and qualitative data. So you might talk about the number of staff members that are approached to participate in delivery within a given study, and you might talk about the proportion and the representativeness there, but you also might just do qualitative focus groups or key informant interviews that give you a sense of, what the context is for adoption. Implementation in this case is also typically descriptive. It includes quantitative, usually cost and fidelity, and in our work and the work of others, a lot of times we're using things like fidelity checklists where the people delivering the intervention identify the objectives that were achieved within a given session, and then we average that across sessions, and then also track the cost of the things that we do, and also qualitative information that can be gleaned from the people that are delivering the intervention, as well as from patients, if we wanted to ask patients about what their perception of the intervention delivery was. So we can get some really good information from both descriptive and quantitative and qualitative data on implementation. And then within a type 1 design, maintenance at the patient level is also usually the primary outcome, and it's usually a distance beyond the end of the active intervention. And it's oftentimes also the target of the intervention in a type 1 design. And then maintenance at the organizational level, typically with these types of designs, is going to be beyond the scope of the project, because what you're really trying to do is understand first and foremost effectiveness, and then get a sense for what might get in the way of implementation. And so it's not very often that we do these types of trials with planned sustainability before we have that evidence in hand. But, you know, one of the things that we have talked about in some of our papers is just the idea of trying to identify the potential for sustainability using similar types of qualitative feedback that you might get from key informants who were those delivering the intervention, as well as those that might have organizational decision-making over if something could be implemented and sustained within a given setting. Okay, so the questions that we started with was, you know, where are you intervening, what are you providing descriptive data on, and what might be beyond the scope of the study work really well for type 1 trials, but what about types 2 and 3? So some of the issues that you start to run into is that type 1 hybrid trials have a single intervention. It's very similar to what we're used to with REAIM, which is applying the model to effectiveness or efficacy trials. But when you get to these type 2 and type 3, there's always going to be 2 interventions, but they can vary based on the design that's used and how each of those interventions is assessed at each level. And so here, the example I have here is you could have a clinical intervention compared to standard care. You could have a clinical intervention compared to another intervention, so a comparative effectiveness trial. You could have a clinical intervention compared to no contact control, or you could have a clinical intervention relative to time, so a pre-post type of thing. And then you can also have, or you will also have, an implementation strategy, and then you would compare that again across these different, or using different methodologies. So you really, when you look at this, and I don't know that this is the extent of comparisons that you would have for each of the interventions, but when you look at these, you can see there's a lot of different trial types that you could see, even if it was simply a type 2 implementation effectiveness hybrid design. It could have a clinical intervention across these different comparisons using different ones, as well as an implementation strategy across these different types of comparisons too. So it gets trickier. And so we tried to come up with some questions to start with to look at type 2 and type 3 trials. And this is where I will remind you that this is intended to be a discussion starter, so really interested in what other people think. But one of the things that we think is critical to ask is, if you're doing a type 2 or type 3 trial, is what is your clinical intervention and who's the target audience? So that's not very different than we do with most other REAIM types of assessments. When we talk about the target audience here, it is those whose health will benefit, right? And so then the second question you might ask is how you define your implementation strategy and who's the intended audience for that. And so in this case, the intended audience is usually those whose practice behaviors you intend to change. So it's not that their health is going to benefit, but it's that their practice or the way that they interact with patients or participants will change. And then the last question is, what REAIM indicators are you addressing for each intervention? And so I think sometimes where there's some confusion in the REAIM literature is when folks do studies where they're testing an implementation strategy and a clinical intervention, but they kind of pull both of those together within their REAIM indicators. And so I wanted to give a little example, and thanks to Carla Galaves, although her last name has now changed since she's married, Arredondo, and the team that did the POSA Activa intervention. And with this one, it was a hybrid type 2 trial. And so I just wanted to give you an example of how we identified what REAIM dimensions we were going to assess, and then what the data was that was used for it. So if you look at this one, again, I'll use my little pointer here. You can see our clinical intervention here was the 5 A's. Most folks hopefully are familiar with the 5 A's of behavioral counseling that start with the assessment of the patient all the way through arranging to follow up on goals that have been participatorily set. And so the 5 A's was really what we wanted to try and test within the family medicine practices in the Jalisco province in Mexico. And so we defined REACH as patient participation rate, those who were invited and agreed. So those, and I guess that's actually opposite. We would have agreed over invited for our participation rate. Then we'd have the sample characteristics and the representativeness, comparing those who agreed to the eligible patient population. So we've all seen that before. For effectiveness, we operationalize that as changes in physical activity and quality of life within the patient compared to patients in a standard care. For adoption, we assess the degree to which the 5 A's were adopted and recorded in the medical record. And for, this is another thing, folks oftentimes what's the difference between adoption and implementation and operationalizing? And for us, the way that we operationalized adoption was if any one of the 5 A's were recorded, someone was considered to have adopted. And then for implementation, we operationalized that as the degree to which all 5 A's were implemented after the training. So, did they get all 5 of them in? That would be 100% implementation. If they got 4, it'd be 80% and so forth. And then for maintenance, we looked at changes in patient physical activity and quality of life in the long term, so beyond the intervention by 6 to 12 months. And then also we looked at the organizational level maintenance, sustained implementation of the 5 A's in the long term. And in this case, again, it was 6 to 12 months after we had initially trained the physicians on the intervention. Okay, so that looks pretty straightforward from the clinical intervention. And so now, since we are doing a type 2 hybrid trial, we also have an implementation strategy. And so this implementation strategy is a theory of planned behavior designed physician training. And we also had another piece that allowed patients to prompt their physicians to initiate the 5 A's. And I won't go into detail on what each of those were, but we have these in combination. So we didn't really have necessarily a comparison between 2 implementation strategies. We had a comparison of this implementation strategy relative to people who did not receive the training. And so for this, the way that we have REACH defined is the physician participation rates in the training. Again, those that agreed to participate versus those that were invited. And we also look at the sample characteristics and representativeness compared to the eligible physician population. So again, this is an implementation strategy. So it looks unusual for a lot of folks when they see REACH at a delivery agent level. But in this case, the people who are intended to have their practice improved are the physicians. And so they're the target population for the implementation strategy. The effectiveness here is the degree to which the 5 A's were implemented after training, because an implementation strategy is trying to improve implementation. And then the second one is implementation of the 5 A's intervention among prompted versus unprompted physicians, which we had some comparisons there. Now adoption here, again, this is where things sometimes get confusing for folks when we're comparing this, is the adoption rate is relative to the training course, to the theory of planned behavior physician training across the 13 regions in Jalisco, right? So there's 13 sanitary regions, which is like public health regions in Jalisco, and in this particular case, all 13 of them agreed to receive that training. And so the implementation assessment here, and this is always a little confusing when you have implementation and implementation together, but the implementation assessment of the implementation strategy is the degree to which there was high fidelity to the theory of planned behavior training strategies and the cost of those training sessions. And so we collected information on both of those things. And then finally for maintenance, it's the degree to which the 5 A's were implementation, sorry I didn't complete that whole word, the 5 A's implementation continued 12 months after the training, and the degree to which, from an organizational perspective, the trainings were sustained annually across, again, those sanitary regions in Jalisco. So, you know, as we walk through it that way, it feels like it's not that confusing, but where confusion does tend to arise for folks is that if you were paying attention with those two tables, implementation for the clinical intervention is the same measure as effectiveness for the implementation intervention. So let me say that again in case I stumbled over it. Implementation assessment for the clinical intervention is the same measure as effectiveness assessment for the implementation intervention. Okay, so that gets confusing for folks. The second thing that's confusing is individual level maintenance for the implementation intervention, so the training, is the same measure as organizational maintenance for the clinical intervention. Again, that's kind of confusing. And then finally, you can have more confusion because each of the REAIM dimensions, even though we're just talking about the E and the I with these hybrid trials, each of these dimensions can be targets for unique interventions. So you can have an intervention that is unique to improve reach, and an intervention that is unique from that reach intervention that is intended to improve effectiveness, and so on. So, and yeah, I guess I wanted to give you the so-ons here. So if you see here, here's some possibilities. So we've just talked a lot about the implementation effectiveness hybrid designs. We could have reach effectiveness hybrid designs where you test alternative interventions to enhance the proportion and representativeness of participants while also testing alternative clinical or community interventions on effectiveness. You could see another one could be effectiveness maintenance hybrids. And then I think Jamie Zellner, I don't know that she's on the call, but she, in her SIP Smarter intervention, there are two different, there's an effectiveness intervention that's compared to matched contact control, and then there's a maintenance intervention that is different from the effectiveness intervention to try and see if that can help folks maintain their sugary beverage reduction. And so I won't go through reading all of these words, but you can get the sense. You could also have adoption implementation hybrid designs where there is a focus on interventions that improve organizational decisions to initiate implementation, and then you have a whole different implementation strategy that focuses on fidelity to that implementation over time. Then you could have implementation sustainability hybrids where you look at strategies to help initial fidelity and then subsequent interventions to ensure a sustainable fidelity over time, or adaptation, or a sustainable fidelity to principles over time. So I don't know that that's the exhaustive list of possibilities, but it gets confusing. And so, one of the things that we wanted to talk a little bit about here is, how can we keep moving forward with these types of designs, use REAIM in a way that makes sense and is practical and doesn't get kind of overwhelming on all this stuff. And so here's some initial recommendations that I jotted down earlier today. So again, please, anything that you can come up with would be great. So if you're using REAIM in a hybrid design, I think the first thing that's really important, actually these first 2 points, are that you're defining what your interventions are and you're defining the target audience for each of the interventions very clearly, so that people can distinguish between the two intervention strategies and the two intended audiences. One of the things that we found helpful is to create a REAIM table for each intervention and include columns for the following. You'd have a column for each REAIM dimension. You'd have a column that indicated whether you were attempting to intervene or change that dimension, whether you were attempting to describe it, or if it is beyond the scope of your study. And then a third column would give you a sense of the source of data that would be used across each of the dimensions. And then for type 2 and type 3 designs, where I think things can be the most confusing, you know, a recommendation is to, when you're reporting on implementation, provide the data in the results of your implementation strategy testing rather than with the clinical intervention testing. So you don't end up having to report these data that are, in essence, doubled up across your two interventions. And I believe that is it for today's discussion starter. So with that, I will open the floor to questions.
Let me just say thank you so much. That was really wonderful, Paul. Do we want to have just a few general announcements before discussion?
Sure.
Okay, so I think Samantha reminds everybody, if this is your first time coming, this is a perfect example of what the REAIM group does. That is, every other month we have a distinguished, very distinguished person come and speak. So we're always looking for topics. If you'd like to join the group, get to the website. You got it from Paul, www.re-aim.org. So please do join us in the future. And now, why don't you just self-monitor what you want for questions?
Sounds good.
Thank you. Hi, everybody. This is Samantha. Sorry, I just wanted to follow up that basically what we're asking is if you'd like to join the listserv to be aware of who our next speaker is. We can send along the PDF flyer that we'll develop for each of our speakers every other month so that you can disseminate that to others so that we can have as many guests as possible. And we really appreciate all of you for joining. I don't have any questions in the chat box, but please feel free to ask Paul your questions now.
Hopefully it wasn't a showstopper.
I have a question. This is Marcia. You said it was really hard to find type 3 designs. And so do you still think that that's a theoretical concept if we can find very few practically?
I don't think that it's a theoretical concept because, you know, to me, in some ways, that's where we start to get into the area of, you know, quality improvement overlap with some of this implementation intervention testing. And so I think, you know, I really wanted to try and find someone that was using how Curran and colleagues was defining type 3 trial. And so I think that there are people doing that type of work that just might not be calling it that. Because, you know, in many quality improvement initiatives, they do track the behavior of the practitioner, but ultimately they're still tracking the health of the patient. And so by definition, you know, that's a type 3 trial because you still end up with two different strategies, you know, one to improve quality and then whatever that evidence-based intervention is that's helping to improve patient health.
Thank you. Question number 2, which of these hybrid models do you think would be most successful in our traditional review structure, like at NIH? Do you have any words of wisdom, both as a reviewer and a potential applicant?
You know, I think that type 1 trials are probably, I don't want to say the most competitive because I think you could have a great type 2 trial that would be very competitive as well. But, you know, by using the type 1 model, you're enhancing an effectiveness trial to really help move things along by providing that contextual information on what implementation might look like. And so I think those ones tend to be rated, or maybe a little bit easier. Nothing's ever easy to write for a great score, but it's easier to say, here's what we're doing from the effectiveness standpoint, and we're adding on all this great information related to how in the future we'll be able to implement it in this type of delivery site. So those ones, I think that have a better chance right now. I think with the type 3, I would say those are probably the hardest ones, because, you know, usually you're talking about a system. And so, you know, coming up with a sample, you know, and the sample size, and then usually it's also not, because you're talking about a system, it's harder to write a randomized control trial, which, you know, even though we have great implementation and dissemination calls, you know, sometimes it's still hard to get a non-traditional methodology through. So I think that one's a little bit more challenging. And then I really think that the type 2 is really where we should be going, you know, where we're doing comparative effectiveness and testing out different ways to improve the implementation. But what I found is that then it's really difficult to get enough information on the clinical intervention for the reviewers and enough information on the implementation strategy for the reviewers to make them satisfied that you've got everything together. Having said all that, you know, I'm still optimistic that someone could use these designs and be successful with funding.
Thank you.
Hey, Paul, can you hear me?
I can hear you, Diane.
Okay. I had several mute buttons I had to unmute, so glad I broke through. I had a question or maybe a thought regarding sort of changing the definitions of reach and effectiveness when focusing on providers and having all those different permutations. To me, it's always been very straightforward that reach and effectiveness or efficacy was the ultimate target population, and adoption and implementation and maintenance at the setting level. Even when you were recruiting providers to try to change their behavior, still to me seem to fall under adoption, because ultimately, you know, their focus will be to affect the health of the patient that they deal with. So I'm just curious as to what others think about your the example in that one paper regarding defining reach and effectiveness, implementation, you know, at the reach and effectiveness at the provider level, given that it makes, to me, makes it kind of confusing.
Yeah, to you and everybody. Yeah, I think, you know, so I'll give my thoughts, and if anyone else wants to pipe up, please do. I think it might be Phil Morgan might be on the call here, that there's some folks on the call that have done some of these different types of trials. And I think the thing is, Diane, is that, you know, when we started on this stuff, we really were focusing on, you know, effectiveness interventions or these clinical interventions or community interventions where we're trying to change patient health. But there is some value in, if I've got a new implementation strategy, in understanding the, you know, the proportion of providers that would engage in that. It's worth us understanding the characteristics of those to determine if we're developing trainings that might be very attractive to some types of providers but not other types of providers, and then that cascading effect that could occur when you do get down to testing the clinical intervention in practice. And, you know,
why not, sorry to cut in, why not, they'll call that adoption, you know, percentage of providers and their characteristics is also defined under adoption in a type 1. So why would we change that? It may be that reach and effectiveness at the patient level is beyond the scope. I really liked, you know, so that kind of language, but you still would be able to look at outcomes at the provider level. It's more the you know, mixing the terminology to avoid the confusion.
Yeah, I guess the issue would be, Diane, is that there's a different adopter for the different levels. So, you know, with the POSA Activa study, adoption was really defined at the training level. And so did the different regions actually adopt this training? And then in terms of adoption for 5As, that was really at the provider level at a much more local, with a much more local focus. And so I think it would have been hard for us to say we're going to talk about adoption of this training program and use the same, but then put it under adoption with the clinical intervention descriptors. And I think that's, and I think, Carolyn Finch has done some of this as well. And I think that she kind of uses a little bit of a hybrid between what you and I are both suggesting. And, I think we just need to come to clarification on, how we're going to use this type of model at multiple levels, and with multiple interventions. Anyone else want to respond to that one?
Paul, this is Phil Trotter. Can you hear me okay?
Oh, hey, Phil. Good. Yeah, how are you doing?
I'm doing fine, thank you. The discussion is exactly, as you know, I think what you were alluding to, some of the things that we've been doing out in the field. And from a pure adoption standpoint, we find ourselves as what we now call community care collaboratives, where we're actually working directly with the system to establish integration between clinical care and community care. So we find that our first chore is finding adoption with the system itself. And we see population health management as being the driver. So we're working specifically about to get their understanding about how community care can be integrated into the clinical care side and to adopt that. Then at the same time, we have the adoption of the community, specifically the professionals within the community, where we can create a workforce that we call the community care team, and then they deliver the preventions and interventions that the system wants to provide. And then we probably have one more buy-in, and that's actually the actual locations that we use, which these days are more shared risk than, or shared use.
Mm-hmm. Yeah, and I think Phil, that's an issue with adoption where you're talking, and so for those who don't know, Phil is deeply involved in the Exercise as Medicine initiative and working to get exercise as a vital sign within health records, but then also not just stopping there, but trying to design practices and community relations in a way that would provide good, meaningful follow-up to support physical activity change. And so, as you're talking through that, Phil, it really highlights the issue when we're talking about a clinical intervention that has a lot of components like exercise as medicine, that there are also, a lot of different agents within that adoption bucket that we could talk about, from the systems level to the clinical level, and then to the community and the community engagement level, and then also, you've talked about developing a workforce of the EIM professionals, which is another adoption, all related to this idea of getting the exercise as medicine intervention integrated.
Well said. Yep. And so I guess that's a huge hybrid approach, I guess, when we try to measure our effectiveness within establishing a collaborative, within a community. How good are we at working with leadership at the system level, being able to pull together that workforce, and then at the same time find those locations within the community that are willing to share their spaces. And so far, that seems to be, it's sort of in the name of making population health management successful. It seems like that there's a definite route there for us.
Mm-hmm. Yeah, absolutely. And I think that Mark is also on the line here, and I think, you know, some of the interesting things that, to kind of loop it back in even to Diane's question, is that, you know, there's different folks, you know, I'm thinking right now of Liz Joy and the work that they're doing with Intermountain Healthcare, and trying to, you know, they really do have this training level of intervention that is distinct from the EIM intervention relative to the patients, and so they really are starting to move towards more of this hybrid model. Mark, I don't know if you want to comment on that at all. I feel like the bad teacher pointing out a student and asking them to respond. Not that you're a student, Mark. Maybe he doesn't have volume. Okay, other questions?
We do have one from Heather. It says, is it your recommendation to conduct these types of trials in a sequential manner? So completing your type 1 trial, get the results, complete your type 2 trial, etc.
That one, I'd love to hear Russ's thought on that. You know, my inclination is, yeah, I'll let Russ answer too, but my inclination is that, you know, I think if you have good clinical interventions that you're still in a place where you want to test the effectiveness, I don't think I would wait to test that effectiveness to come up with good implementation strategies to test that. You know, I'd much prefer to see a heck of a lot of the type trials.
That was very echoey. I don't know if someone wasn't muted, but could you repeat that, Paul?
Oh, I think I can repeat that. Basically what I said, Diane, was that, you know, I don't really think that sequentially is the way that I would approach that.
Sorry, still a problem. I don't know if it's just me or if others, we can only hear every other word if that.
It's clear on my end.
Okay. Sorry, Diane. I'm not sure if maybe it's just your line, that North to Alaska line. But I guess I'll just reiterate one last time. I like the idea of lots of hybrid implementation effectiveness type 2 trials. I don't know if Russ has any volume, if he wants to.
It doesn't look like it. I don't have the opportunity to mute him, so I'm assuming that means he doesn't have the opportunity to speak.
Okay. Well, we're getting down to the last few minutes. Any other questions, comments, smart remarks? Feel free to use the chat thing too if you wanted to send questions in that way if we can't hear your volume.
I have a question, Paul. This is Samantha. My question, I guess, kind of goes back to one of the previous questions about funding as well, and where I'm getting kind of hung up, particularly when looking at Coran's paper. So if we have an implementation strategy, which is operationalized as a bundle of implementation interventions, so multiple different things, so maybe continuing training or support or electronic medical record reminders or kind of all of these things, I wonder, how do we communicate and or measure so that it's clear to ourselves which implementation intervention is actually increasing the adoption rate and the implementation fidelity? I guess because I kind of think about it as, if we have an intervention where we throw in a bunch of behavioral strategies, how do we know which one? So the same thing could kind of be extrapolated to these implementation strategy bundles.
Asked and answered, Samantha.
Okay.
Yeah, I think it's exactly that. You know, we didn't talk about this at all today, but I think for implementation strategies, it's as important for us to try and assess mediators of action as it is for behavioral interventions. And a lot of folks for a long time have kind of argued about the degree to which you want to, test, self-monitoring and goal setting, or self-monitoring by itself and goal setting by itself, and to try and get, where's the real thing. And I think when we're talking about adaptive types of designs and fractional factorial types of designs, you can start to get at that type of thing. But I think for an implementation strategy, I kind of go back to the place of, the number of settings and people that you would need to do those types of designs would be really challenging. And so, I think identifying what we think are the mechanisms of action and trying to develop potential mediational models, that can help us to understand what's the real driver.
Yeah. Thanks.
Okay. Well, are there any other questions there, Samantha?
There are none in the chat box. Thank you all so much for joining. We will create a blog post for www.re-aim.org. I did put that in the chat box as well as requested by one of the attendees. So you could click on that link directly. And don't forget to sign up for the listserv so that we can let you know who our March speaker will be.
Yes, and if you'd like to volunteer to be a March speaker or June speaker or an August speaker, please let us know.
Yes, thank you.
Well, thanks, everybody. This was really fun for me. It made me have to go back and think about a few things, and hopefully it'll make you think about some things too.
Thank you, Paul. Thank you, Marcia.
Thank you.
Bye. Thanks, Marcia.
Thanks.